Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Til Luchau.
Welcome to the Thinking Practitioner.
The Thinking Practitioner Podcast is proudly supported by ABMP Associated Bodywork and Massage Professionals, the premier association for dedicated massage and bodywork practitioners like you. When you join ABMP, you're not just getting industry-leading liability insurance, you're gaining practical resources designed to support your career. From free, top-tier continuing education and quick reference apps like Pocket Pathology and 5-Minute Muscles, ABMP equips you with the tools you need to succeed and grow in your practice. ABMP is committed to elevating the profession with expert voices, fresh perspectives, and invaluable insights through CE courses. Their own ABMP podcast, Massage and Bodywork Magazine, sponsoring this podcast and featuring industry leaders like my co-host Whitney Lowe, who is not here with us today, and myself, Til Luchau, in their magazine. Thinking Practitioners listeners like you can get exclusive savings on ABMP membership at abmp.com/thinking. Join the best and expect more from your professional association. My guest today is Professor Werner Klingler from Ulm University in Germany. Professor Klingler, you are a physician, anesthesiologist, fascia researcher, and your work bridges muscle physiology, pain medicine, and the body's connective tissue system. Dr. Klingler has spent much of his career exploring how mechanical, neural, and fascial properties interact, from the way anesthesia affects muscle tone to how connective tissue tension and sensory feedback shape movement, pain, and perception. He's been part of the fascia research group in Ulm with Dr. Robert Schleip, who's also been a guest on the show, helping connect the laboratory and the treatment room, bringing insights from physiology and anesthesia into dialogue with what hands-on practitioners observe every day. And as someone who guides patients through profound physiological shifts and studies the body's subtle states of tone, tension, and relaxation, he brings a fascinating lens to questions that might matter to all of us who work with touch. What actually happens when the body lets go? And why do these states like anesthesia, trance, deep relaxation, ecstatic states perhaps, or the quiet openness sometimes we witness in bodywork often feel so meaningful or so healing? And what can we as practitioners learn from the physiology of these states about supporting change, recovery, integration, all those good things? Professor Klingler, thanks for your patience through the introduction and welcome. It's great to have you here with us.
Til, thanks for having me.
So good. I met you for the first time. I'd known of your work for some time, but I met you the first time at the Fascia Research Congress in New Orleans recently, where you were talking about the altered states that involve anesthesia. And you captured my interest in your description of them. I've been looking forward to this conversation. But people use a lot of different terms for these states, like altered states, top-down, regulated states, trance, restorative states. What do you have a term you prefer, and why? What do you like to call them?
Well, this is a debate which is going on in my specialty for quite a while. So roughly 10 years ago, a colleague of mine, he said as an answer to this question, a patient is not a submarine. Because when you talk about a submarine, you have different levels of diving depths. So in other words, you just say 100 meters below the sea level, this is a diving depth. And so what many people talk about, they just share this thought about the mental state. So he is in deep sedation or less severe sedation. So more or less, this is not a correct way of just describing what's happening to the brain.
Why not?
So basically, even if it's easy to think about a submarine, so of different states of consciousness, we should rather think of an octopus, because an octopus has several arms, and just one arm is above on the sea level. The other arm is very low in the deep sea. And so basically this describes much better what's happening in our brain in different states of trance, in different states of consciousness. So what we do in anesthesia, we measure the level of consciousness by measuring an EEG, an electroencephalogram, which is basically the electrical currents which are produced by the neurons, and we just process them. So it's not so easy to just have an overlay of these different levels as you might have seen an EEG reading before. This rather looks a bit complicated. However, if you look at these different states of anesthesia, you find out that different frequency bands get upregulated, others get downregulated. Interestingly, so the alpha spectrum is divided in alpha 1, alpha 2. And this ratio, alpha 2 versus alpha 1, is a strong indicator of basically what's happening in the brain. And so we use this ratio in modern anesthesia as a method of just giving an estimate what's happening in the brain. And so we have different areas in the brain which disconnect during anesthesia. And so I could go on for hours, but just to answer your question in a very short way. So basically what happens, it's a dissociation of different parts of the brain, and they don't talk to each other as we are talking to each other right now.
So the octopus's arms stop communicating with each other, or perhaps, like you said, there's in different places or different depths. Is that the analogy you're describing?
That's exactly the metaphor for this, just what's happening in the brain with our different parts and neurons.
Okay, so from your research, what's happening at the tissue or fascia or muscle level when we relax deeply? Not just mechanically, but perception, interoception, those levels.
So just to turn it around, if you just look at the muscle value of the person, so as an anesthesiologist, you might ask, what do I have to do with muscle? I just care for brain and nerves, and just I care for local anesthetics. However, we do a lot of muscle relaxation, because if people are operated, we cut the bowels open, and so people need to have a full relaxation of the connective tissue of their muscle tissue, and so this is what the anesthesiologist does. And so what we do, we supply a drug which basically stops the neuromuscular excitation contraction coupling. So by stopping the acetylcholine attaching to the muscle tissue, to the motor end plate, the muscle is not able to contract. And so we measure this, of course. We have sort of an EMG measurement, which helps us to get an idea of what's happening again. But again, we have roughly 30 isoforms of myosin. Myosin is one of the main ATPases, one of the main enzymes in our muscle, which gives, let's say, the tonicity and the interaction between actin and myosin as the contractile elements of the muscle. So basically, we have not this one and only muscle. We have a very, very different way of muscle tissue in our bodies. And so these muscle tissues even differ with content of connective tissue, and they differ with the amount of nerves per muscle spindle and per muscle. So there are a lot of variables which we have to take care about. And so we have specific muscle analogies which we know. So let's say if we want to look at the neck, we use the small hand muscles. If you look at the bowels, we look at the diaphragm. So there are several ways of just getting an idea of how the muscle is in the relaxed state. If you inject a very, very high dose of muscle relaxant, then we can make sure that all muscles are just paralyzed. And so what really rests is the resting muscle tone, which is basically the tissue property of muscle. There are titin molecules, there are actin molecules, there are myosin molecules, there are set bands connecting these together. And then on the other hand, outside the actual muscle fibers, there are connective tissue, collagen fibers, and there are nerves. And interestingly, nerves have a biomechanical stability, which you can even notice when you just stretch your arm as fast as you can, what happens? You get at a point where you might feel some neurotension, some tingling in your fingers. So this is because this element is the nerve which is just causing the restriction. So it's we call it neurotension.
So the anesthesia inhibits the muscle firing, contraction, and there's lots of different ways that happen. So you monitor different muscles to see what's going on. And then you're also dealing with neural tension in the limbs as well. Am I following you so far?
Yes. So basically, the 3 columns of anesthesia is muscle relaxation. So it's one part, and we do muscle relaxing drops, which we inject to keep muscles relaxed. Then the second column of anesthesia is more or less the brain control. We just make it unconscious when people are sleeping. And the third column is pain control. And even if people are sleeping, they suffer pain, of course. And so we do not want them to suffer pain, even if they are sleeping, because this influences a lot of processes which we might help to understand. Even if we have a brain dead person, and we just take out the heart, we take out the lung, then we've got a physical reaction, even if by definition this patient has no brain anymore. He or she is dead. And this person, even then, we apply drugs which are painkillers just to prevent this autonomic nervous reaction which occurs even without a subjective pain feeling. So these are the 3 columns: pain, muscle relaxation, and unconsciousness or the consciousness.
All right. So we're talking about anesthesia. How do those map out onto other states like trance or deep relaxation and body work or sleep or ecstatic states? What's similar or different about those different states?
Well, basically, with our drugs which we inject, we just influence different parts of the brain, as I outlined in this, let's say, the metaphor with this. And so we also influence the different levels of our hormones in the brain. And so the main circuits which we influence are these movement circuits, which are regulated by dopamine system and the serotonin system. Then we, of course, all the metabolic system is just regulated by adrenaline system, noradrenaline system. And then we have this relaxation system, which is by GABA, the GABA system, which is another important system. And the most important stuff about all these different hormonal circles, which we control under anesthesia, is that those different hormones, they all interact with the cholinergic system. And the
cholinergic system, yeah.
The cholinergic system in our brain is responsible for thinking. So maybe you know that Alzheimer leads to reduced cholinergic system. Then we also know that the metabolism is strongly linked to this cholinergic system as such. And so this is what we influence. So basically, we know about our different drugs, and we know what kind of system we can influence. And so furthermore, it's even more important that our hormonal system works at as a specific pH level. So if you look in textbook, you can see all different kind of drugs. They have a pK value. So at what pH value there is the optimum dissociation of the drug, and the active ingredient is just taking action in the body. And so we strongly influence this dissociation activity by just monitoring the CO2 level in our bodies. And so we even use this to to regulate the mode of action of the drugs. And so we in daily life we even can do this. And you probably did this before. If you take breathing activities, you can easily get into different, let's say, pH levels. It's only a slight difference, of course, if you don't do it artificially in the artificial ventilator, but it's effective enough to change the mode of action and the activity of drugs. So in other words, if we are in an
mode of action of drugs, but also of the physiology itself, because there are altered states that comes with different breathing patterns like breath work or
exactly.
Yeah.
So if you use breath work, when that's what we do in anesthesia. So at the very beginning of anesthesia, we try to keep people in a very, very relaxed state. We want them to have, let's say, a mode of the drugs working very well. So what we do, we do a slight hyperventilation. So we just try to lower the CO2 level. So what leads to a slight increase in pH value. And we know from our chemical studies that this helps the metabolism. So we can save drugs because the action is better in these conditions. On the other hand, if we want to just get the activity back of the body, so we use this mechanism to revert the whole process. So we just try to develop a sort of an acidic environment in the body, and this helps the metabolism to kick in. And so when we just tell people, or when we try to finalize the general anesthesia, so we stop or we lower the breathing rate, and then the CO2 levels rise. In other words, the pH level drops a bit, so they get a bit more acidic, and the metabolism kicks in. And so when they wake up, they feel fresh because all this, let's say, the stored CO2 has been ventilated out of their bodies before. So, but we can do this, or you can do this at home easily, because if you do your breathing exercise, you get rid of your stored CO2, and this may last. So in COPD patients, if we do this for an hour or so during controlled anesthesia conditions, they feel fresh for at least even 1 or 2 weeks after, because all these CO2, let's say, stores are emptied, and so they have a problem with their CO2 control anyway because of the COPD, and so this helps them. So we can do this.
So increased breathing helps empty out these stores of CO2, and these effects can last quite a while.
That's right. That's correct.
Okay, back to the question of the differences between the states. And I know you're an anesthesiologist and you know a lot about that. I'm wondering if you can help us think about just the relaxation we witness in body work. How is that the same or different from what we're talking about with anesthesia?
Well, so all we learned just now is let's say the scientific backbone of how we can control muscle tension and connective tissue tension. So finally, we have a very different system. So the muscle tissue is dedicated towards active work. So we use these active contractile elements to do motor work. So so maybe 2/3 of our body or brain and nerves are just dedicated to muscle work. On the other hand, connective tissue around muscle and nerves, they support the muscle work, and they work differently. So when muscle tissue gets active, so connective tissue gets loose and just takes itself back in its action, because muscle tissue gets warm, temperature rises, and so the muscle tissue takes over. So if you would just compare it, you have maybe 100% tension when in total, and you compare a warm and a cold condition. Under warm condition, when muscle is heated up, and so our temperature is not homogeneous in our body. So when we are talking right now, our muscle in the arms are maybe 33 or 32 degrees Celsius. However, if we do physical work, then we heat them up maybe to 38 degrees Celsius, 39 degrees, even higher up, because this is just work we're doing with our muscle. And so then in warm conditions, muscle takes up 80% of the load. However, in cold conditions, connective tissue takes up the load, so takes up 80% of the load. So this is how our system is regulated. Very smart, and it's a sophisticated system. So if you would think of all components, you need to influence the neural system. So if you just use your breathing techniques, as I outlined before, if you use your, let's say, power output in the muscle machinery, so if you heat it up, then your connective tissue has the chance to get loose. If you don't heat it up, the connective tissue can't get loose. And then in the end, if you have the third component, this connective tissue, nerves, and muscle, they can have timed relaxation. So first, get the muscle warm, and then do this relaxation, and do even the breathing technique, and you get a better relaxation. So, but I think this is what you know much better than I, how to do it. But this is the physiological background.
You've broken it down into some very specifics with the breathing, with the relaxation, with the warmth and the temperature. And you're saying when all those things are online, we get more arms of the octopus involved in this process. Is that right?
Exactly, because the link between all these issues, which are very technical, is the autonomic nervous system. And the autonomic nervous system basically is the most prominent reflex circuit in our bodies. And so if just to compare it with anesthesia, I can just use this reflex circuit very often in our daily life. So if we just to give you an example, if you do an eye operation and you turn the eye around, you take just a little fork, you place it under the eye muscle and you turn the muscle. So this is a strong activator of the parasympathetic axis, and so the heart will stop beating. And so what you do, you just release the muscle tension, heart gets again, starts beating again. And
my heart's stopping just listening to you describe this.
here are, well, if you want, I can send you a video afterwards, so just showing this rough briefly. And then
Sure.
if you look at other sides of our body, so if we open up the belly, then there is the omentum, which is basically a big network over all these bowels. And so if you just take a tear on this omentum, which is again an autonomic, let's say,
Structure.
and it's an autonomic stimulus, again the same thing happens. What do I tell the surgeon? Please stop tearing the omentum and the heart will go on. And so we have a lot of these autonomic systems, but the point is, if you stimulate this nerve system, even if there's an parasympathetic, sympathetic nerves, other nerves, so our human beings are just the parasympathetic axis always is the first to react. So in our world around us, the first reflex and the most prominent reflex is just to stop. And the heart stops for a second. And then after this, it gets fast and we run away, whatever. And so this is what we can observe in anesthesia very well. And so we make use out of this.
You're saying what we sometimes call the freeze reflex or the stopping reflex is the first thing, and then the fight or flight kicks in. Maybe what Stephen Porges calls dorsal vagus. I don't know.
Yes, exactly. Exactly, that's it. And so, and we can observe this. And so what happens if we use this, then we try, of course, to get people in an autonomic state where they can relax. If they are frightened and the emotional state is elevated, so they are afraid of suffering from pain, or the operation does not go well, then we have an altered sympathetic just axis, and so this doesn't help us, because then the pain tolerance is reduced, and so we try to use the autonomic nervous system a lot just to influence people's process going through this operation in the perioperative period. And so what we do, we try to give them acupuncture maybe during this perioperative period. And the best is to have a close communication. And we even do some autonomic work. So but just a very, very...
This is pre-anesthesia, on the preparing the context or the state of the client. Yeah.
Just very, very, very easy exercise. If you have a patient which is, well, you can communicate very well, you just tell him to take cold water 3 days in just before the operation. Take cold water in the face every morning, just to activate this axis. And so this
Cold water in the face reactivates the vagal reflex and slows things down, parasympathetic elevation, etc.
Exactly, and this helps helps people to get through this perioperative period. So this is basically what we do.
It's fascinating to me to think about, as an anesthesiologist, that you're preparing the client or patient's state for the intervention, for the treatment itself. And I remember very sophisticated visualizations. I was with my wife through many surgeries. We're getting ready for that, and sitting on the beach, imagining things, your favorite place, where do you want to go, taking the time to really prepare her mental, autonomic, emotional context for the medical procedure. And I'm thinking we as body workers could learn that a lot too, that we're working not just with fascia or just with tissue or muscles, that there's a lot we could learn about preparing the autonomic and emotional context for what we're working in.
So actually, this is a very good way for describing it. Actually, if you look at the brain again, and so you look at the emotions, so we have different areas of the brain, all of you know about this, and there is this limbic system where emotions are, they are produced. I don't know if you can tell it like this, but emotions are just circulating neural activities in the lower parts of our brain. And so this is called pupils, circle, or limbic system. And so what happens? So during an epileptic seizure, I will just briefly describe, because if you look at the temporal part of the brain, which is obviously very prone to epileptic seizures for some reason, because there is a sort of a very sensitive area there, we observe that the emotional system is part of the epileptic seizure. So if we do an epileptic seizure in hospital, so we observe exactly, we ask the clients, and so I can send you again, if you want, I can send you a video. Then what happens? This epileptic seizure involves the emotional feelings of the person, and what happens? The maximum neural activation is all over the brain. The person is shaking, and give a guess. What emotion do they suffer? Because the epileptic seizure also is a maximum activation of this limbic circuit. And so what kind of...
Sounds scary. It sounds like I would be afraid at that moment, but I don't...
Yes, you got it. So the most prominent emotion which is displayed in our brain is fear. And so if you just stimulate, as I told you, if you do a maximum stimulation on our body in the nervous system, you get this response. As you told us, the dorsal vagal compartment. And so we stop. And this is the same. We have a lot of fear if the maximum motion. And I don't want to go into just metaphors, but if you look at some politicians, they exactly know how to use this, well, society, this idea of this frightening for controlling societies. Look at some parts of the world.
Sure. Well, and then there's the reverse or converse. How do we engage other parts of the brain? Do we have some powers as a conductor of these different instruments or these different arms of the octopus? Do we have the power to bring online different parts of the brain besides the dorsal system or besides the sympathetic? Is there a ventral vagal pathway, for example?
Yes, of course. So basically, if you look at the higher function of the brain, so this is what we call a cognitive reserve. So if you use a lot of connections, so if you train it basically as you would train a muscle, then you can just improve not only your motoric system, but also your brain, your pain tolerance. And so you can also improve your, let's say, longevity. And this has been proven very well.
Let's go back to the state that bodywork produces, when you're very relaxed, say, or altered, or a sense of floating or timelessness that clients describe or that we know from receiving it ourselves. What's happening in these terms? What's happening with the octopus or what's happening with these different parts of the brain?
Yes. So if you would use an EEG measurement during such a treatment, you would observe that the different spectra of your frequency bands, they change. So we have different areas in the brain with different sine waves, and so the
electrical activity within the
electrical activity will change, and so the bands will lower, and you could even measure this very easily. However, this is just to show that your mental state is altered. You do not know exactly which parts of the brain interact and which doesn't. So I think research is not so, we can't prove this. And I can tell you that even in anesthesia, where a lot of research is going on about this brain connectivity, we have a lot of boundaries, because if there is between the age of 20 and let's say 60, we have a roughly good understanding what's happening. As I told you, the alpha 2 level is rising up, alpha 1 is going up down, theta is going up, and so on. However, if you look at some individuals, this doesn't fit at all. So there are a lot of individual changes, which is a very individual system. And so I think it's similar to the pattern if you look at back pain people. And there is, I think it was Paul Hodges from Australia who tried to find a system. If you have back pain on your left lower back, which muscles are the compensatory activation for compensating this low back pain on the left side. And so he made a map and tried to find out, okay, left lower back pain, I always have more tension on my other side, its opposite side. However, what was the result of the study? Everybody has a own compensation mechanism. So the one has on this side more tension, the other was. So there is not a clear picture. I think this is what makes us being human, because we have so many different ways of compensating. And even if you look at the stress, so we are, as I'm an anesthesiologist, we are into delirium, postoperative delirium. So what happens? We have, let's say, 60%, they are hypoactive. and 40% or 30 or to 40% hyperactive. So if you look at the
During the anesthesia experience.
postoperatively in the
Postoperatively, okay.
in the postoperative room, they get agitated, they are unwell, the blood pressure is rising, they are talking some crazy things. So they're just in another world. And 60%, they are hypoactive. And so basically, if you do the same procedure the next week at the same patient, and you can't guarantee that next time he's hypoactive or hyperactive, maybe he's different. And so look at your personal condition at home. You might have a fight or an argument with your partner. One day you just fight with your partner, you shut the door and so leave me alone, I don't want to hear anything, and just I'm quiet in my room, quiet in my own. The other day, 2 weeks later, you have the same system, there is a scratch in the beautiful car, and you get an argument with your partner. And then you start fighting. You are an idiot. You made a scratch in my brand new car, which is very expensive. And you start fighting. And so the same person can react completely different. And so the decision is made in our autonomic nervous system within milliseconds. And so we try to learn how we can influence for giving a hypoactive or hyperactive. And actually what we do in the operating theater, in the postoperative care room, we inject a drug which heightens the cholinergic system. So we try to improve cognition. So basically what you can do in your bodywork field, if you improve the cholinergic system, so the way of thinking, so as you do, just the fantasy, traveling, relaxation, you just go from relaxation to activation and back. So what you improve the cholinergic system, and you avoid that you even get into this decision of arguments or just leave me alone, a hypoactive state. And this is what we can prove in anesthesia. So if you have a person which is very well educated, which has a high cognitive reserve, as we say, and so the probability for getting into this very agitated state is lower than if you have a person who does not do some I would say body
Didn't go cognitive first.
has no positive body let's say relationship to his body.
Okay, I need to catch up. This is fascinating. You're saying that one way that you help patients regulate postoperatively is by engaging their cognitive parts of their brain.
Yeah,
Now, remember-
exactly.
Yeah, in trauma work, we talk about reassociating with the body, but there's another branch of trauma work that says, ask a question that the amygdala cannot answer. And so at that moment, if we start actually perceiving or looking or thinking about things, that's another way of dealing with hyperactivation. Is that along the same lines?
It's the same line, but all everything you're saying is true. So I can just add a few comments. So what we do in this situation, we try to get the thinking going in the correct way. So we help them with their hearing aid. We help them with reminding them of their partners and so on. We try to do this to just improve cognitive activity. And this helps in many cases.
I'm thinking how after a bodywork session, we're often in a non-cognitive place. We're very much in our bodies, very relaxed. And there's I don't want to take people into thinking too hard. I remember back when we had written checks in the US, we don't have them anymore. People send electronic payments, but no one wants to pick up their phone and do payments after a session like that. But you're saying they're in a post-op session, you want people able to function again. So maybe a little different.
Yes, maybe what you could consider is to ask your colleagues about their own experiences, because I'm very sure that if you do bodywork, so if you just practice from getting from a relaxed state into a very active state during such a session, then I would guess, and I'm rather sure that during an operation in the perioperative state, there is a less probability or lower risk for getting into post-op delirium.
Okay, so that's what's being avoided is post-op delirium. I think we're might have different goals in body work, of course, but
Maybe this is something you could ask your colleagues.
I'm curious. That's a great suggestion.
If they had an operation themselves, did they go through anesthesia very well? Did they go through anesthesia not so well? So this is probably what you can ask.
So many questions here. One is that I'm remembering the kind of emotional states that can happen for people post-operatively too. I mean, I experienced that myself recently with a colonoscopy. So it was conscious sedation. It wasn't deep anesthesia. But upon waking up, there was a very tender sadness that emerged for me. And my companion who was driving me home was a little concerned. But for me, just weeping away, it was actually very cleansing. And there's a sweetness to it that was part of that reemerging into conscious world. You see that in anesthesia too, don't you? Other kinds of anesthesia.
Oh, yeah, yes. So this has to do with these different hormonal systems in our brain. So what we influence is our serotonergic or serotonin system, which is linked to our just well-being and feeling good. And so, of course, this has to do with the drugs which we apply because they just induce a rise of serotonin levels, and then after this they get lower. So this might have to do with the sadness you were experiencing. On the other hand, every operation is sort of a stress for the body, even if it's just a small intervention. What happens? Corticosteroids are getting flushed through our body. And so if you just a rule of thumb for every anesthesiologist, so it's one unit of cortisone per kilogram. So in my case, roughly 100 units of cortisol I have in my body every day. And so during session operation, this 100 units of cortisol are maybe doubled or at least 150%. And so cortisol usually is a strong emotional enhancer. So when you're getting the cortisol levels rising, then your emotional state is probably getting in a more positive attitude while you're on this just rising axis. However, after this, you get sort of a lowering of this cycle, and then many people have a feeling of feeling depressed, and even worse during birth and delivery. So this is what many people observe, that during just pregnancy, finally a baby gets delivered, everybody's very happy. After this, all these positive hormones just get flushed away, and so people run a sort of a sadness, even if they have a newborn baby.
So like a hormonal hangover.
That's a good word. That's a very good word. I like this word.
Okay, so this is something to think about and be aware of. That experience, I know this is not uncommon, that people report beneficial insights or emotional experiences after deep body work or anesthesia or these other kind of trances or breath work like we're talking about. And I'm thinking about how that hangover risk is there, that there's a possibility of also being depressed or lower afterwards.
I won't think that bodywork has a hangover.
I would
because I can just give you a reason why. So if you look at any sort of beneficial training, our body is more or less a cyclic system. So we have blood pressure, it's going up and it's going down. We have the hormonal cycle, cortisol in the morning going up, we're going up. So everything in our body is cyclic. And so if we forget about this cyclic pattern of our body, we have a problem. So, and this is basically what's happening in our modern society. Look at me. I am tonight, I'm having this phone call. Tomorrow, on Sunday, I've got hospital work. Then I'm on call in the night. And so my biorhythm is disturbed. What happens? My system between activation, deactivation doesn't work as it should work, or it's as it's constructed by nature. I tend to increase my blood pressure. My blood sugar level is increased. Everything is out of balance. And so if we want to rebalance, we should just know about the cyclic nature, and we should train the cyclic nature. Coming back to blood pressure. Our blood vessels are controlled by the autonomic nervous system. They are controlled by adrenaline, noradrenaline, and all those, let's say, neurotransmitters causing the metabolism. So the blood vessels contract, blood pressure is high, blood vessels relax, blood pressure gets low. We can see this. Even if you drink a cup of coffee, you can see the differences. So what happens? You need to train the cyclic nature. And people in the very, very, let's say, 50 years ago or 100 years ago, they knew about this system. So they stepped their feet, cold water, then warm water, cold water, warm water, cold water, warm water. So basically, they trained this cyclicity of the blood vessels. And so this can
like push-ups, like autonomic push-ups somehow.
Yes, autonomic push-ups. Yes, maybe this is a good word. Like you are so good in finding correct words. So, and this happens in many aspects of our life. Just think about sexuality. You have an excitation, then orgasm, relaxation. So same thing, and this happens throughout all of body. And we should try to practice this autonomic push-up. This is a very good word in any way we can, even in daily life. And if you do body work, in my opinion, this is part of this cyclic training.
That makes a lot of sense.
Sleep, awake, excitation, relaxation. And so try to let's say, think about this in a word in a way of the manual treatment. Basically, what you're doing more or less is treatment of the autonomic nervous system, 80% or 50% of your effects.
You've given me a lot to think about, and there's a lot of information here as well as these descriptions of the processes involved. There's one particular thing I'm still puzzling about and thinking for myself, and that's the way that these states dissociate the different parts of the brain, you say, or produce a disruption to our usual way of assembling things. It's almost like things get less associated, less constituted, less constellated in the usual way. And in that process of coming back together after returning to ordinary life or something like that, there's a possibility of coming back in a different way. It's almost like a reset or a reassembly is possible after a body work or after one of these deep experiences. Do you have any thoughts about how we steer that or how we might actually positively influence that?
So I'm just talking about you because I know the extremes, of course. Yeah. And in the hospital work, we have people who have extreme problems with their brain. So they are deeply depressed, or they are in a stupor. I don't know if this is the correct English word, but stupor means that they even can't move because they are in a deeply psychotic phase of their life. They just think you need to give them artificial nutrition because they can't move. They are in a stupor, or they are deeply depressed. What we do, we try to give them drugs, of course, and then after a while, the drugs they even are not strong enough to help. And so basically, we place electrodes around the brain, and so we give them sort of electricity through the brain. And so what happens, similar to an epileptic seizure, all these neurons will release their neurotransmitters, and it's sort of a reset. And so basically, this is what you were describing. This is an extreme version. And it's in a high percentage is very helpful because all these neurotransmitters are cleansed more or less. And so it's possible to do a reassessment, a resetting. And so in our daily life, the resetting is done on a different way because you just introduced me. I'm a physiologist, and that's true. And so guess how we do the cleansing in daily life?
Tell me.
We use our tears. If you analyze the tears, so there are a lot of neurotransmitters inside. So basically the cleansing is not only just losing water or something to change the volume of your, let's say, brain. So we just change the neurotransmitters in our brain. And so we just try to get rid of...
Weep them out.
Whip them out. So to come fresh.
Fascinating.
This is basically the extreme. And so if you use body work, I think you're doing this on a much better and softer scale. Not as an extreme version as in a cardiac arrest. You would do the defibrillation exactly the same. To do the defibrillation, then all neurons or all heart cells are put at rest, and then the heart can start over on a regular rhythm. And basically a similar thing is happening in the brain.
It brings up really interesting questions for me about how muscular relaxation is related to our perspective or our emotions or our insight. Because we talked about them just now as almost like they're separate arms of the octopus or have separate functions almost. But it's interesting to me that when we relax deeply, we come back in a different way, that there's a whole different perspective that emerges too. This is some of the puzzle that I wanted to unpack with you.
Well, if you look at children, you can observe this very well. So I do a lot of children anesthesia. So if you work with 4-year-old or 3-year-old, they are in a complete state of being connected to their parents. And so then they fall asleep, and you give them an idea of, let's say, a fairy tale or some cuddle, some pet they like. And so when they wake up, they have very, very large pupils. And these very, very large pupils, they show us that the state of their brain is cognitive function is coming back into the brain. And so in adults, you can see it, but not so clear because it's the time course is shorter. However, in children, they have 2 or 3 minutes. The pupils are wide open. And this is the cholinergic system has just a fight with the other hormonal systems in the brain to kick in back cognition. And so this is an indicator that cognition is coming back. And then after the pupils get smaller and the children, they get back to life, they have this perspective, a completely different perspective. And so you can even see when they sleep, when the connection between the parents and this cuddly toy and so on is a very calm situation. And so you can even see that they can take up this idea when they wake up again. However, it's a constant fight between these symptoms, and it's not always, I cannot always just steer it in the correct direction. I try, of course, to give them as much as positive input as possible, but sometimes the emotion, fear is overwhelming. So I try to avoid this by giving them cognitive aid as much as cognitive symptoms as well. So I think the answer is to improve this cognitive cycle. Relaxation, activation, relaxation, like this cognitive push-ups and autonomic.
Nice. There's, I know that Robert Schleip has speculated about this some, but there's questions about the value of sensation in the changes we see in body work. And for example, under anesthesia, people's range of motion at their shoulder gets much bigger. And there's questions about, would body work under anesthesia produce the same effects as someone who's not anesthetized? Does the sensation of the work have an impact as much or more than the tissue and objective tissue effects?
Well, we did this. And with Robert Schlatt, we did a video about this. So I took Robert with me in the operating theater. So we had this nervous system compartment syndrome, what is basically a connective tissue thickening around the nerve. It's a nerval entrapment syndrome. So people have in their arms, they have a nerve running down the arm, and then basically they feel some tingling, and so it's not very pleasant. And so what we did, we took a camera, as we do in operating theater. We took the camera inside this nerval sheath. We looked under the skin, and so we saw the restriction. And Robert did this manual therapy on this compartment, and then we found out that there are loose connective tissue bundles which cause this nerval entrapment. And so you can even, with this massage, Robert could just break some of these connections. However, then we got further up where this entrapment was even worse, where the nerve was even swollen. And then he did really strong manual therapy. But even then, in this very single case study under camera, we couldn't just get rid of this very tight entrapment. So then we had to use the scissors just to open up this nerval entrapment. However, on this part where it's just a partial entrapment, it was helpful. So I'm very sure that it works, and so you can. It does work, of course.
To do manipulation under anesthesia, so there are actual tissue effects.
Yes, of course.
Okay.
There are tissue effects. You can even do it a bit more effective because the patient has no pain. Because you want to do a biomechanical, you have several aspects. The biomechanical work to loosen up restrictions. If you have a scar to lose restriction, you can do manual work, or you can inject some saline just to loosen up the tissue. This will work under anesthesia for sure. Then there is a second aspect. This is the sensory component. If you want to use the sensory component for getting a rebalancing of the autonomic nervous system, I think this is better without anesthesia. But it might work with anesthesia as well, because if you look at the reflex circuits under your anesthesia, they are still okay. They still work. So we do reflex circuits under anesthesia. We just check them, the H reflex and so on. And this is still working under anesthesia. And so if you do this, if you do manual work and you influence this reflex circuits, which is altered in chronic pain, then you can influence this as well, I'm sure.
It's fascinating to think about the different targets we have in our work. Is it tissue? Is it reflex arcs? Is it sensation itself? Talk about the sensory rebalancing that could happen under a non-anesthetized state, or the tissue effects might even be, we can go farther with an anesthetized state. Okay, so what about working with people that have just had surgery? Are there things body workers should know about themselves or their patients, their other clients who have just come from surgery or have recent anesthesia? Any thoughts about that?
Well, the thing is, if you analyze all surgery patients in the Western world, so in the developed world, so I think the US, Europe, and so on, so the mortality after surgery is 2%. So it's quite high. So if I look at my operating theater, we have, let's say, maybe 50 patients getting operated every day. So we lose one in the time span of 3 months. So I think you should, if you want to improve mortality, from my perspective, it's probably another topic. However, then you need to look at the autonomic nervous system, because if you look at those people who die, in 90% of the cases, they die because of the cardiac problem after surgery. So what manual therapists can do, because surgery is obviously done in elderly people most of the time, they can care for the cardiac system, and the cardiac system needs to calm down. So we know that if the heart frequency is below 60 or 55, then the mortality is much lower. And I'm very sure that a manual therapist can very effectively influence the heart rhythm. So just if you lower the sympathetic activity and you lower the heart rate, then the person has a significant benefit.
Maybe there's a role preoperatively too. Maybe surgery preparation, body work would have a role in that as well.
Yeah. Unfortunately, there was a study in the UK examining, I think, 3 or 4 different systems of versions of physiotherapy and just checking if the outcome is better, and they could not prove a benefit. So I don't think that this is the end of the of the story. However, in this preliminary first data sets we're getting, the effect, the scientific proven effect is lower than as we expected, unfortunately.
Interesting. Curious about the study.
Probably this is not yet investigated in a very
Well, thank you for talking us through these points, and thanks for the speculation. Final thoughts, summary, things you'd like people to go away with?
Well, I think the final thing is that you should be sure, or you should be aware, that fascia is a very important part of our body, and fascia is alive. It's not just connective tissue, which is passive, so we can work with it. It's restructuring, it's remodeling, and it's very important for sensory aspects, for our autonomic nervous system, for our biomechanical stability, and for our humoral and hormonal system.
Thank you. Thank you, Werner. We'll put some links into those videos you mentioned, maybe this study. How can people find out more about these topics, or what other resources would you like to leave people with?
So, I mean, the best way is to look into the books which have been edited by Robert Schleib, because all the content I was talking about is in these books. However, if you have more details, then you can even follow Til Luchau's just blog and Til Luchau's just work. I think you have a lot of extra literature as well.
Thank you, Werner. How about the Fascia Research Society? We should give them a mention here too. We should make people aware of that. What do you want us to know about the Fascia Research Society?
But the Fascia Research Society basically has been built to foster science and networking between researchers and manual therapists. So basically, I would encourage everybody to support the society, because they are, I know that they are working as a non-profit organization to try to make events happening. And so the last event in New Orleans was obviously quite difficult. I don't know details, but it was difficult to get going. And so the next conference will be in Europe, I hope, because for me it's easier to travel. And so you might be interested in coming to the next Fascia Research Congress.
We don't have a date yet, but yeah, it's coming, we know. Yeah, the last
September 2028.
November 2028.
September 2028.
September. Okay.
I'm not involved.
Well, this is not the official announcement. Okay.
Just a speculation.
Great. And then,
Because usually they do it in September. That's just
and then the challenges to getting the last conference started, there was concern that various logistical, financial, et cetera, challenges would get in the way. But in the end, it ended up being amazingly well attended and quite well received in many ways. Werner, you had another resource for people, or another idea for people. What was it?
So everybody who is interested in sharing his expertise is invited to join the Freckles project. So Freckles is an abbreviation and stands for fascia researchers' consensus and liaison statement. And basically what we're doing, we try to get knowledge from basic manual therapists and researchers and to include this into a big database and to get people talk to each other, and just even if they just read about different strategies researchers have and manual therapists has, this will help us. And so I just want to invite you to be part of something bigger. And this bigger project is this joining together, this networking between all these different specialties. And so finally, you can even be co-author on a scientific publication, which is basically the product of this networking process. And so if you would like to join, just register at freckles.org, FRECLS.org.
Okay, we'll put a link to the Fascia Research Society. We'll put a link to these things you mentioned in our show notes. Thanks again, Dr. Klingler, for talking with me. I'll go ahead and thank our sponsors, and then we'll say goodbye. Books of Discovery has been a part of the massage therapy and bodywork world for over 25 years. Nearly 3,000 schools around the globe teach with their textbooks, e-textbooks, and digital resources. Books of Discovery likes to say, learning adventures start here. They find that same spirit here on the Thinking Practitioner podcast, and they're proud to support our work, knowing we share the mission to bring the massage and bodywork community thought-provoking and enlivening content that advances our profession. Instructors of manual therapy education programs can request complimentary copies of Books of Discovery's textbooks to review for use in their programs. Listeners like you can explore the collection of learning resources for anatomy, pathology, kinesiology, physiology, ethics, and business mastery at booksofdiscovery.com, where Thinking Practitioner listeners save 15% by entering Thinking at checkout. Thanks to all of our listeners, you all out there, and to our sponsors. Stop by our sites for the videos, the show notes, the transcripts, the extras. Whitney Lowe will be back. Here's a site, though, where you can find those things, academyofclinicalmassage.com, my site, advanced-trainings.com. And we want to hear your ideas. We want to hear your feedback. We want to hear your input. Email us at info@thethinkingpractitioner, or just look for us on social media under our names, Til Luchau and Whitney Lowe. We, as always, would appreciate it if you would rate us on Spotify or Apple Podcasts. It really does help the sponsors know that their support is well given, and it helps other people find the show, which is always great too. Take a second now just to go give us a rating. And thanks as always for telling a friend. Thanks again, Dr. Klingler, for joining me today.
Goodbye.